who is MD, DM, MD from Banaras, MBBS from Banaras, and DM from Kanpur. Actually, he is double DM. You'll be surprised to know that when he got DM cardio, before that he had already appeared for IAS and he had already joined. He had the joining letter for district magistrate in one of the districts. But when he was going to join, his father informed him कि भाई आपका ना वो DM cardio का आया है कानपुर का कुछ जरा ये देख लो. And then sir decided that he will be our colleague. So a bureaucratic clause was medical fraternity's gain.
And
so
it took a very good decision for us.
Yes, it took a very good decision for us. And he has been such a wonderful gain for our fraternity. So I hand over the CME to him. You know, he is the director of Cath Lab and Max at Max Hospital. But for me, more important than anything else, I think he is one of the best human beings that we can come across. So I request Dr. Viveka sir to take the podium. Friends, ladies and gentlemen, welcome to CME number 944. Wow.
Well, so good evening, friends. After such a kind introduction and the felicitation ceremony, we come to the real science. What is there is that there are a lot of things which have been going on regarding stents and antiplatelets and what are the medication one should have. So if you see that what we call there, you must have seen the terms called DAPT, that is dual antiplatelet, which has been the real success story after putting a stent, how the patient would remain even free for 1 year, and then the guidelines still say that we should give dual antiplatelet for 1 year, that is aspirin and clopidogrel. But now we have got antiplatelets like ticagrelor and prasugrel, so that should be given for 1 year. What we do is that the drugs which are very potent, that is required for initial few months, so after 3 months or so, we switch back to aspirin and clopidogrel, which is considered to be pretty safe. So if you look at this stent thrombosis, the reason why we give 2 antiplatelets is that we should not have clot in these stents. So you will be surprised to know the history of angioplasty, because it's been a real boon, because this has contributed. So there is a, if you look at the reason why the humanity has started living longer, is that there are people who are getting myocardial infarction, acute coronary syndrome and all, and they get treated and they move on. So it means that if there is a blockage, acute myocardial infarction, they would get a treatment done, and then they would not have the mortality, because if you don't treat the acute myocardial infarction in time or acute coronary syndrome, almost 30% of the people would not reach the hospital if they are not treated in time. So it means that this is the biggest killer. And also the patients who have got left main disease, triple vessel disease, there also the problem would happen. So the dual antiplatelet has really been a savior, but it is a double-edged sword. So if you give too much of it, then there is a risk of bleeding. So bleeding not only in gums and the skin bleeding, but the most serious kind of bleeding like intracranial bleed, the GI bleed, needing blood transfusion, so on and so forth. So I think this is something where we need to rationalize the uses of blood thinner, because blood thinner is a savior, but it could also become a problem for the given patient. So we need to know that when should we bring the patient, because we are moving in a direction where we are moving from major things to minimalistic things. So not only in surgical space like open heart surgery, we have replaced with the TAVI and angioplasty. Similarly, the dual antiplatelet, we want to bring it to single antiplatelet as soon as possible, but not at the cost of increasing the thrombotic risk. Means that we should not decrease the medication and at the cost that they would have increased cardiovascular event. So we need to, in next 10-15 minutes, we'll be deciding that why, when and where we should bring the dual antiplatelet to single antiplatelet. So there are many patients who we call high bleeding risk, HBR group of the patient, where the high bleeding risk would prevent us from using dual antiplatelet for long. So there are few stents, current generation stents, where we can come down on the dual antiplatelet after a month or 4 weeks, and we can just give a single antiplatelet. You'll be surprised to know that when we started, before I became an interventional cardiologist, there were a lot of bleeding complications because the patient would receive aspirin, ticlopidine, and then heparin also. So the risk of hematoma, because the radial angioplasty was not been long at that point in time. So a lot of patients would die because, not because this clot in the stent, but because the hematoma, bleeding, and so on and so forth. So the bleeding complication is something which we are a big killer for at that point in time. So the rationale for the use of antiplatelet therapy during PCI is to reduce the thrombus burden and flow obstruction, because we were thinking that it is only the heparin which protects at that point in time. Then we learned that as you inhibit the platelet much more potently, probably you will do the job even better. You don't need to give. So we started with angioplasty where 20,000, 15,000 units of heparin was being given, and today in our lab we give just 5,000 heparin and the job is done. So it means that the bleeding complication has come down significantly. The other problem which has been surmounted is that apart from going from the femoral route, where because the bigger thighs and the not so much of accuracy of compression of the access site, the patient used to have large hematoma and retroperitoneal bleed, but when you have a radial access, you can compress it then and there. It's not a big space, so it's again a savior. So when we give the antiplatelet, we need to reduce the thrombus, we need to reduce the periprocedure damage and prevent stent thrombosis. Because remember, a stent we don't give because we want to put a stent, we want to protect the patient from ischemic event. But what if you put a stent and then the clot forms? Because at the end of the day, it is a foreign body, so it invites a lot of clot formation. And in the era when there was no potent antiplatelet like fluoroquinolone, then the patients used to have a lot of the stent thrombosis as well. So we need to look at that. So where is the sweet spot between ischemia and bleeding? So we need to come to a spot where we don't really have, the patient should not have clot formation, that is ischemia, and should not have increased bleeding risk. So this sweet spot has been found that you decrease the dual antiplatelet. You look at the acute stent thrombosis, subacute stent thrombosis, post-PCI, acute myocardial infarction, acute cardiac syndrome, because that is your foot and foreign body, it will invite clot formation, but after 4 weeks, 6 weeks, and more importantly 3 months, because the chloride data showed that up to 3 months you have increased risk of stent thrombosis. But after 3 months, if you de-escalate the antiplatelet, you will have lesser risk of complication. So after 3 months, we say that you need to decrease the dual antiplatelet, and if the patient is high bleeding risk, then probably we can come to single antiplatelet. So the solution is not so simple. If we de-escalate far too early, then we will invite clot formation. So how long do you keep a patient on dual antiplatelet? If you look at the guidelines, it says that we need to give them for 12 months. It means that 1 year, and still the guidelines says that we need to give antiplatelet for 12 months. If we look at the guidelines, even if you have not put a stent, if the patient had acute coronary syndrome, had a troponin leak, increased CPKMB, then the patient should be on dual antiplatelet because the risk of reclot formation is much more higher. But we have seen that off balances by risk of increased bleeding risk. So we need to look at the patients where the patient has at a higher risk of bleeding or higher risk of clot formation. So bleeding and thrombotic risk has to be calculated very well. To the patients who have got multiple risk factors, like patient has got recurrent acute coronary syndrome, patient has got multiple stents, more than 3 stents, bifurcation and left main stents, where the stent thrombosis will result into catastrophe. We should give for longer, not even for 12 months, but we should give it for 3 years, up to 3 years it has been seen. The patient who has got diabetes, uncontrolled diabetes, and has got a CKD. So these are the things where the patient would need longer dual antiplatelet, that is aspirin and clopidogrel. But what about the patients who are elderly, those patients who has got very low body weight? So there they will come with patches on the skin because there is a subcutaneous bleed. So in those situations, we must de-escalate. So that is what we call the high bleeding risk patients. There we need to de-escalate it much earlier. So there are a lot of data which came right from 2014 and till 2019. We have had the guidelines also came that we can de-escalate in patients who are high bleeding risk. But what about low risk acute coronary syndrome patient, low risk PCI patient? There also after 3 months we can come to single antiplatelet. So how long should the DAPT be continued? So the data is saying that 3 months, 6 months, 12 months, 24 months and 30 months. And the answer is that all of them are correct based on the patient risk profile. So currently available evidence speaks of for individualizing the duration of DAPT, taking patient risk and ischemic and hemorrhagic event into the account. So suppose you have put a single stent in a patient, you should not be really finicky about that the patient should be on dual antiplatelet, even if he is 80 plus, even if he has got 4 millimeter or more than that artery size, even if the stent size is less than 12 millimeter, then there is no point in exposing him on a risk of increased bleeding. So we need to come down on that, and that is why the ESC has come with a guideline that 12 months of dual antiplatelet therapy is recommended as a default. But as we say that the guidelines are only for guiding you, but they are not gospel truth. We need to individualize the treatment, and the patients who really need long duration of antiplatelet, they are the patients who are younger, have got multiple risk factors, they have got diabetes, chronic kidney disease, and so on and so forth, bifurcation and all. But in the, we have accepted that after 1 year we need to de-escalate to single antiplatelet. But default strategy for 12 months after acute coronary syndrome is class 1 recommendation, level of evidence is A. So we need to, we have done a PCI on January 1st, we need to continue up to December 12th. But what about the patients who are low bleeding risk group? There we can de-escalate after 3 months or 6 months. So in elderly and all, those who are low risk for bleeding and complication risk, we always go in that direction. So if you look at the real life scenario, there is a guy who is just 59 years of age, coronary artery disease, hypertensive, hyperlipidemia, has sudden onset of headache and mild dementia, severe nausea. So what we found is that these are the patients who had, you can see that the patient has a cerebral hemorrhage, and this is the complication on dual antiplatelet which we read about, because if the patient is on dual antiplatelet, the patient is bound to bleed in the brain. So if the brain bleeding happens, that is a catastrophe, because that is an indication where we need to stop all the antiplatelets. So is it to prevent only stent thrombosis? Answer is no. The stent thrombosis is prevented by a combination of therapy of aspirin plus thiopurine, but aspirin is not something where we cannot do without that. So if you stop aspirin, it means that you are de-escalating the antiplatelet, and that is why we have gone into an era, we call it metal-less PCI. When you do a metal-less PCI, it means that you have not put a knee stent. It is like you have done a drug balloon, or you have done an absorbable scaffold, and then after some time you don't really need an antiplatelet. So this is like a bypass surgery where you have not have any foreign body in the patient's body. The patient has got a own venous graft or arterial graft, so they will not have any problem even if you stop antiplatelet for few months, few weeks. So similarly, those patients who are at a higher risk of bleeding, we need to go into what we call metal-less PCI. So to prevent the cardiovascular event, we need to see that the patient who has had a one event or had a prior myocardial infarction, that's why we are more, concerned about the patient who had a myocardial infarction. There is more than 100,000 patient data which shows that the patient who has had a myocardial infarction, they have another event if they are completely off the antiplatelet. So we need to be very, very careful in those group of patients. And cardiovascular event between 1 to 5 years would be nearly, keeps on escalating. So up to 20%, so 1/5 of our patients would have acute coronary syndrome in the 5 years down the line. So we need to give them antiplatelet, but not the dual antiplatelet, otherwise the patient would have risk of cerebral bleed, and which is the most serious consequence. So we have got many patients who would have, the subdural hematoma, bleed and all, and this is something which is a, deterrent for that. So 6 months versus 12 months. So if you see, there's a lot of patients where after, so the patients who are low risk, we try to de-escalate after 6 weeks, 6 months, so that the risk of bleeding is not there. So why is not DAPT? High bleeding risk for the patient. So HBR group O. So who are the patients who are at a higher risk of bleeding? So the patients who are elderly, age more than 70, renal disease, patients who have got liver disease, active cancer, anemia, and the patients who have got low platelet count. Because end of the day, these antiplatelet would decrease the platelet count and make them dysfunctional. So if you give too much of that bleeding risk will obviously go high. And then the patients who are having chronic kidney disease, eGFR less than 60, patient who have got cirrhosis, patient who has, in past 12 months have been actively treated for the active cancer, and if the patient has got chronically low hemoglobin, then obviously we need to work on that. If the platelet is less than 1 lakh or 100 per, 10 square 3 meters, then obviously these are patients where we need to be careful. So this is something where we call it, and then concomitantly there are a lot of patients who would need oral anticoagulants, would need, have got a bleeding gas, there is old stroke, intracranial hemorrhage and so on and so forth. So obviously these are the patients you cannot make a general rule that dual antiplatelet should be given. So obviously this is something where a trial was done where the comparison, so when we de-escalate the patient from dual antiplatelet like aspirin and clopidogrel, whether to continue the clopidogrel or continue aspirin, which one is a better molecule, then this data is very convincingly shows that 36 months of dual antiplatelet with clopidogrel versus aspirin, you can see that this clearly shows that the clopidogrel aspirin monotherapy, you have more event, whereas DAPT event is significantly lesser, and this clearly shows that among patients who received a drug-eluting stent and were event-free at 12 months, ischemic outcomes were non-significantly reduced and extended duration of DAPT. It means that we are unnecessarily giving them dual antiplatelet. Now, one of the problems in our country is that we have got triple drug combination, that is, gold form, aspirin, ecosprin gold, or Rosebus gold, and so on and so forth. So it means that because they become cheaper, if you combine aspirin, we keep on giving them, and that's not good because patient is financially supported with that combination, but with that the risk of bleeding is significantly higher. So there is a clear-cut shift in the guidelines also. The guidelines also shows that ESC guideline, that is European Society of Cardiology guidelines, management of acute coronary syndrome. Again, they say that after 3 to 6 months of DAPT, in patients where we suspect that the risk of bleeding will be higher, and we define them as an HBR group, which we have just discussed, is that we should de-escalate the antiplatelet, and so we should have a specific individualization of antiplatelet therapy so that the problem does not happen. So the reason why we are safer now with single antiplatelet, there is an advancement of stent design. The earlier stents were thicker, 120 microns. Now we are dealing with just 60 micron stents. It means that the risk of thrombosis in the stent will be significantly lesser. There are several studies in meta-analysis demonstrate that this is quite a safe strategy, and there is a more awareness of the high bleeding risk population, because as the population is growing older, we need to, look at that we are not creating disease, we are treating the disease. Because there is no, point in treating acute coronary syndrome and giving the patient cerebral bleed. So we need to be very, very careful about that. So when you look at the short DAPT versus standard DAPT, the good data shows that if you de-escalate the antiplatelet, you're not increasing the risk of mitral infarction, risk of stent thrombosis. You can see the odds ratio is hanging just at the neutral point. It means that you are decreasing the major bleeding, but you're not increasing the stent thrombosis. It means that we can safely de-escalate in most of the patients. So that, and then we need to give them clopidogrel rather than aspirin, because that is much more potent. So it will protect this stent and decrease the cardiovascular event also. So early shift from DAPT to clopidogrel monotherapy would be the name of the game. It has clearly shown that stopping aspirin after 1 month reduces the risk of adverse event by whopping 38%. It means that you are not doing any disservice to the patient. In fact, you are doing a lot of good to your patient. You are decreasing the risk of adverse event by 38%. So we start aspirin clopidogrel, or you can start with ticagrelor aspirin, and after a month where the maximum risk of antithrombosis, the stent thrombosis has gone, you can, put on clopidogrel, and the risk of stent, complications like bleeding, cerebral bleed, and hematoma, and the GI bleed would come down significantly. So we have got the data from master DAPT trial, which shows that the patient with acute and chronic coronary disease who underwent PCI within the last 30 to 44 days were at increased risk of bleeding, because you have given high dose of heparin also during the index event. But what happens after effect of 1 month DAPT followed by clopidogrel alone versus DAPT? DAPT means that you have given the aspirin plus clopidogrel. So 12-month data clearly shows that the safety is much more robust. So you just continue with the clopidogrel. And again, if you look at the host exam trial, clearly compared to aspirin clopidogrel, if you continue on clopidogrel, the risk of problems, the complications will be significantly lesser. And this data is again for 5 years randomization, and clearly the clopidogrel arm is clear winner. So there is no favorable net outcome for long-term DAPT after complex PCI patients with LVR group. So obviously those patients who are currently we are dealing with the high bleeding risk group, we should confine them for single antiplatelet, and that single antiplatelet should be clopidogrel rather than aspirin. So acute early phase and very late phase, there also in both the arms you can see the clopidogrel is a clear winner. So it means that when obviously the statins are the mandatory, so you need to give a statins and then de-escalate to single antiplatelet. So one of the P2Y12 inhibitor monotherapy after 1 month to 3 months DAPT, as I said, if the patient is more bleeding, more thrombotic complications like bifurcation disease, more than 2 stents, patients who have got left main disease, there we can wait up to 3 months and then de-escalate to single antiplatelet. Otherwise, we could go with the dual antiplatelet up to 1 month and then de-escalate. So the latest European Society of Cardiology guideline also says that if you look at the OPD various trial, that also says that the clopidogrel monotherapy is superior to continued DAPT for an additional 9 months. So again, the ischemic risk and the bleeding risk are same. In fact, bleeding risk would be significantly lesser, and no wonder that this trial data says that the switching from ticagrelor. So a lot of patients, our usage of ticagrelor in acute coronary syndrome and PCI patients is almost nearly 95%. A couple of percent we use prasugrel. Clopidogrel we use only in patients who are 75 plus or elderly. So again, if you have gone with the ticagrelor or prasugrel, switching to clopidogrel again in Asian patients is pretty safe. So this clearly data shows that compared to ticagrelor only group, the switching group was not significantly associated with major adverse cardiovascular event. It means that ticagrelor is a much more potent molecule, so the risk of bleeding in high bleeding risk group would be significantly higher. So patient de-escalation time, so what should be the time? The patient who are at high bleeding risk, those who are frail, those who are elderly, there we should change it to 1 month. But I think in the routine cases we should go for 3 months where the stent thrombosis risk is also not compromised. the patient can be easily kept on this single antiplatelet. So I think run of the mill would be that we give a single antiplatelet clopidogrel after 3 months. And again, if you look at the opinion impact of bleeding risk in modulating DAPT therapy, 41% of the cardiologists indicated that they considered shortening of the DAPT due to bleeding concern in few patients, and that data, registry data, has clearly translated into the practice, and that has come into guideline as well, that you de-escalate after a month and things will be good. In the complex PCI scenario, what we call it complex is that the patient who has got left main disease, patient who has got more than a couple of stents, the patient who has got long stents, more than 20 millimeter of stents, then obviously we need to be more safer than sorry. So in those situations, we need to give dual antiplatelet for at least 6 months, or as the guideline says, up to 12 months. So barring that, we can easily de-escalate. So if you look at the oral P2Y12 inhibitors in hospital, and after 1 year anyway we de-escalate to single antiplatelet, and there is a lot of data which suggests that if you use this single antiplatelet, it is better to use clopidogrel rather than aspirin. And we have, recently I had a webinar with Professor John McMurray, and he said that I envy your Indian cardiologists that they have got a luxury of having a combination tablets which in UK and US they do not have. So here we can just give one pill, that is a combination of aspirin and statin, and that is job is done. So the patient compliance also becomes better. So where the situation where you need to be really more aggressive with the dual antiplatelet is that if you have implanted more than 2 stents, means 3 stents or more than that, 3 lesions more than that, bifurcation with 2 stents, more than 60 millimeter stent, and patients who had a chronic total occlusion, that is 100% occlusion of the artery. So these is a situation where we need to be more vigilant, and we can go up to 1 year. But rest of the situation, because the improved technology, and also there is a new thing which has come, is called optimization of the PCI, where we make sure that the stent implantation is 100% accurate by doing an intravascular ultrasound and optic coherence tomography, that is OCT, and that has really made job quite easy, because after optimization you don't really need a very potent antiplatelet. So it means that the major adverse cardiovascular event comes down significantly. And in chronic coronary syndrome, the patient undergoing complex PCI has a higher rate of peri-procedural and cardiovascular event, and that are not reduced by ticagrelor as compared to clopidogrel. So in long run, if you look at the risk-benefit ratio, clopidogrel outscores ticagrelor also in this trial. It means that the antiplatelet therapy after coronary artery bypass surgery, 5 years follow-up data shows also, the DAPT trial that also clearly shows that if you keep your patient on the antiplatelet, and if that antiplatelet is clopidogrel, that will be handy. So the rapid evolution of the field of antithrombotic pharmacotherapy in an ever-changing landscape of safer stents, bleeding avoidance strategies, and newer drugs, secondary prevention requires regular updates and recommendations for dual antiplatelet. But we need to be really patient-centric. We should always, one of the funny things was that when you go to a cardiologist, he says that my patient should not have a complication related to stent thrombosis no matter what. But that's not the correct strategy, because you should not just protect the stent, you need to protect the patient as a whole. And the more the genuine approach is to protect the patient as a whole, so that patient does good in long-term outcome. And the way forward is to de-escalate the dual antiplatelet to single antiplatelet in patients who are high bleeding risk up to 1 month or 3 months, but at least definitely 6 months in most of the patients. So thank you very much for your time.
Sir, thank you very much. Naresh, इधर आओ, ये रखो जरा,
लाइट जला दो
इसको अपने पास रखो. Sir, we had a wonderful session. I would request you to please be here for the question answer session. Very, very good talk, sir, and I am sure that the erudite delegates would definitely have some questions from you. I just wanted to ask you, sir, regarding the dual antiplatelet therapy. if you were to start a dual antiplatelet therapy in a patient, sir, being used for about a year, and then I see your prescriptions being changed to prasugrel and aspirin. So this is something very, very important and revolutionary, actually, the data that you have presented, sir. I wanted to ask from you, sir, once you start using aspirin and ticagrelor after PCI, the minimum duration is 3 months, 6 months, 9 months or 1 year, sir?
Yeah, so I think what am I?
So please.
So if you see that is what I was trying to elucidate, that the maximum risk of western thrombosis and all is up to 1 month and then up to 3 months. So that is why we don't deny that we go on ticagrelor and prasugrel. So do not tolerate ticagrelor because we, issue of breathing complication and all. We change them to prasugrel, but after a month or after 3 months, we de-escalate to clopidogrel and aspirin. So that is the dual antiplatelet because you have use of, ease of use also in those situations. But the dictum of using that dual antiplatelet, prasugrel or ticagrelor for 1 year has gone now. So now we are using, we are shifting after 3 months. So if the patient is not really a very high bleeding risk group, then we de-escalate after 3 months. But the patient who is high bleeding risk, patient who is going for laparoscopic surgery, patient who is going for some surgical tumor surgery and all, then we decrease it to single antiplatelet, and our surgeons are happy to operate them on aspirin. After the surgery, we try and put them back on clopidogrel so that the thrombotic risk benefit and the bleeding risk is balanced very well.
Sir, one of the criticisms of using clopidogrel in a dual antiplatelet combination has been two. One is sir, please, I request your attention, sir, please. One is that it is a reversible P2Y12 inhibitor of the receptors, and second is that there is a percentage of people who are non-responders to clopidogrel. Sir, is there a test to know it, like there were tests can verify now, etc., etc.? Are they available in India readily? And do you do those tests routinely?
Yeah, so I think that's a very brilliant question. So if you see the paradox of clopidogrel resistance and all that matters only during acute coronary syndrome and acute stent implantation. So the risk of stent thrombosis used to be higher if you just load them on clopidogrel and do the PCI and clopidogrel. Surprisingly, after the acute phase is over, that is 1 month or 3 months, after that the safety profile of clopidogrel is much more favorable compared to the newer P2Y12 inhibitors, that is ticagrelor and prasugrel, because the bleeding outweighs the benefit. So this is a funny thing that maintenance therapy with clopidogrel is much more safer, much more efficacious. But during the acute coronary syndrome, and remember, even in patients who are stable coronary artery disease, if you disturb the by balloon angioplasty and put a stent, you're making stable patients into acute coronary syndrome. So there again the safety of the superiority of ticagrelor and prasugrel is still there. In trial after trial it has been shown that it is much more superior for 1 month, and beyond that, or up to 3 months, and beyond that you can just give clopidogrel. And it's quite funny, but it is really quite reassuring that clopidogrel does the trick, because even in the patient, so we don't really do now any resistant test. There was a time when there were a lot of companies who came with clopidogrel resistant test, but now it is thrown in the dustbin because it doesn't matter. You give initially potent P2Y12 inhibitor, either ticagrelor or prasugrel. Prasugrel is only reserved for patients who are not tolerating the ticagrelor, but ticagrelor is the drug of choice in acute situation. And then the time to change is 1 month in patients who are not really tolerating it well, or those who are going for some surgery, or otherwise you do deliver cases up to 3 months. But if you look at the guidelines, they still say that dual antiplatelet, but it does not really say that you need to be on ticagrelor or prasugrel up to 1 year. It says that you can be on DAPT. It could be clopidogrel aspirin, which is much safer and much more efficacious.
Sir, there is an issue of diabetes in India. We are the diabetes capital of the world. And routinely I have seen the practice amongst cardiologists. They use the standard protocols of dual antiplatelets for a much longer time in diabetics as compared to non-diabetics. So the data that you have shown today, does it apply uniformly to non-diabetics and diabetics?
So diabetes is just one of the risk factors. If you look at the high bleeding risk and high thrombotic risk, so DAPT score that clearly shows that the patient who has shown that 3 or more stents, patient who has got 60 millimeter more than that, cumulative stent length, patient who had a bifurcation stent. So these will be patients where the risk is high. Then obviously the patient who had a smaller vessel. So when you come to diabetes, the arteries are much smaller. So in those situations, you need to use DAPT for longer. So you need to be, so it is like horses for the courses. You cannot generalize it once. So you cannot say that the X patient did well with dual antiplatelet and the Y patient will also do. If the patient is, you cannot equate a patient who is 140 kilograms with a patient who was just 40 kilograms. So it means that we need to individualize the therapy, and that is why the definition of the high bleeding risk versus low bleeding risk, complex patient versus simple patient came, and there is a score of DAPT score is concerned. So if the DAPT score is high, we need to not only give up to 1 year but give up to 3 years. But if the score is low, we need to give it only for 3 to 6 months and de-escalate to single antiplatelet. So I think it is the basic motto is that we need to not harm the patient. We should not just aim to protect this leg.
Sir, you beautifully gave the takeaway message that as quickly as possible move from DAPT to SAPT. Are there any compelling indications where you would reconsider this advice? Suppose we move from DAPT to SAPT, what is that single event which would tell us, no, this is not a patient for SAPT and we should revise our strategy just for the audience?
No, so again, I think the same thing will hold true like the patient who has, so the more complex anatomy, the more complex patient, so the patient has uncontrolled diabetes, HbA1c of 11, has got a small artery to 2 or 2.5 millimeter, the stent more than 60 millimeters, and then the patient has got disease, CKD and all. So in those situations where the thrombotic risk is high, we should try and give them longer DAPT. And those patients who are under 60 kilograms, those patients who have got very frail body, so there we should say that we should not. So we should balance the war between thrombosis and bleeding. And in those situations, the high bleeding risk patients, like patients who are cancer patients, where the bleeding risk is higher. So we need to de-escalate the situation in those cases because there is a clear data which suggests that no antiplatelet is the biggest harmful thing. So you need to give at least single antiplatelet in those situations. The patient is high bleeding risk, better to give at least single antiplatelet, and there is enough data to suggest that it is quite safe strategy. With more complex the patient, so there are complexity could be in the lesion, complexity could be in the patient. If both the things are complex, we even go further than 1 year. We can give up to 3 years dual antiplatelet, and the duration is not only from the index event. Suppose up to 1 year, at 9 months the patient has another event, then the time starts from that period. So then again another 12 months.
Sir, my last question. Routinely we prescribe very high doses of statins post the last question and then do all the learned gentlemen. Sir, we prescribe very high doses of statins. When we are using a dual antiplatelet, is there a trade-off between the dose of statin and the dual antiplatelet?
No, so I think the statin is a different ball game. So statin is something which is not related to it. So if you look at the recurrence of event, and that is why the newer PCSK9 inhibitor in this current has come, is that the recurrence is cumulative interaction between the amount of LDL and the duration of LDL. So the lower you keep, the better it is. So that's a different equilibrium. So you need to manage that differently. But as far as the antiplatelet is concerned, that is not related to statin at all.
Thank you, sir. Thank you very much. Dr. Kodar, sir.
Good evening. So you said by default dual antiplatelet therapy for 12 months unless there is high bleeding risk or low ischemia risk. High bleeding risk, you have told some conditions like renal condition, liver failure or cancer patient. What are low ischemic patient where you can stop dual antiplatelet and start single antiplatelet? Like coronary artery bypass, can you start single antiplatelet after 3 months or 6 months?
Yeah, so I think anything which is not high bleeding risk is low bleeding risk. So it means that if the patient has got a bypass surgery, the patient is not acute coronary syndrome or mitral infarction patient, the patient who has got a bigger arteries, 3 mm or more than that, patient does not have left main or bifurcation disease. So these are the patient who are low risk patient, that does not have any other comorbid condition, non-diabetic, well-controlled diabetes. So these are the low bleeding risk group, and there we can de-escalate right from 1 month to single antiplatelet.
And if during first 3 months patient needs urgent surgery like acute appendectomy, then what do you advise?
So we always say that the surgeon, go to a surgeon who can operate you on single antiplatelet, that is aspirin. So now we have seen in our setup, all surgeons have learned to operate on single antiplatelet. So the only two indication where it cannot be done is the intracranial bleed. So there it cannot be, that is an absolute indication that we should stop all antiplatelet.
So patient needs urgent surgery, then you can start single antiplatelet within 3 months also.
Yeah, absolutely, even 1 month. So that is why there are few stents like Onyx stent or biofreedom stent where it has got FDA approval for 4 weeks dual antiplatelet. After 4 weeks you can safely use single antiplatelet. And you should try and use the thinner stent.
Dr. Sajid Parne, please.
Good evening, sir. Wonderful lecture. Sir, I wanted to know if a patient comes to me, he is on DAPT, has a gum bleed, what do I take away first, aspirin or clopidogrel or ticagrelor? I mean, do I have to do that, or do I have to give something like other agent like I give Trenexa or something? What do I do at the? I had a patient who had a gum bleed, and he was having DAPT.
Yeah, so that's again a very brilliant and the what we call garden variety case. So you don't have to stop antiplatelet in that situation. You need to just manage it, say acid, or you can say that they can do a Listerine mouthwash and so on and so forth. So in those situations, if the patient is within the 4 weeks, we should not stop DAPT. We should say that you can use Trenexa because there is data, 3 years data which has shown that if you are giving acid in these group of patients, you are not doing any harm. The risk of stent thrombosis does not go high. You can give them cold mouth, wash and all those things. So in those situations, but if the patient is more than 6 weeks or 3 months, then you can safely stop one of the blood thinners like the aspirin or even clopidogrel. One of the two you can stop.
Which one will be better, sir? Which
So
one will
better
have
is aspirin.
earlier effect?
So better to stop aspirin.
Aspirin first. So any guidelines for us to know that this patient is more likely to have a bleeding risk, high bleeding risk, HPR categorization?
So we said that the HPR category risk is that the patient who has weight is less, those who are the cancer patient has got a very thin body mass index, those who had a previous bleeding history. So these are the things which I showed are the risk of, and then elderly patients. These are the patients who would have.
Right. Thank you, sir.
Thank you, Dr. Sajid. Dr. Luthria, sir.
Good evening, sir. Regarding similar to his question, elective surgery, dental extraction, eye surgery, how early, and patient is already on SAPT, from DAPT shifted to SAPT. Now, how early, how many days prior to surgery should the anticoagulation be stopped, and how much later can it be restarted, and what drug?
You're talking about dental extractions?
Dental or eye?
Eye. So there are minor surgeries.
Yeah.
So do we have to stop SAPT for minor surgeries?
So we don't really need to stop the, even single antiplatelet for the eye surgery or cataract and all, but there are a lot of surgeons who are insistent. They say that unless you stop, I will not do. So we say that single antiplatelet should be stopped for third day, 2 days, and then third day the patient should have surgery, and then next day you can start the antiplatelet.
Next day.
Next day.
Sir, can I add to
Other
that?
than that, next to that, this is elective surgery. A person has ecchymosis, petechiae, or fall of hemoglobin or melena. This is already an expected side effect of the oral anticoagulant. Which one do you stop? How long, and when do you restart?
So the out of all the P2Y12 receptor antagonists are the most potent. So clopidogrel is more potent than aspirin, ticagrelor is more potent than clopidogrel, and prasugrel is more potent than ticagrelor. So you need to just continue aspirin and stop P2Y12 inhibitor, because the risk of stent thrombosis on aspirin alone will not be very high. So stop clopidogrel if the patient is on clopidogrel, ticagrelor if the clopidogrel. Advantage of the ticagrelor is that it is duration of action is just 72 hours, so it will be quicker to wait off from the circulation. So that is something which has to be done. Aspirin is easily tolerated, so it's not a big
If patient is already on SAPT, do you stop aspirin?
So we say that you can stop for, so maximum stent thrombosis and complication happens on beyond day 3. If you stop beyond 3 days. So if you are within window of 5 days, it doesn't happen. So now there is a very interesting data with newer anticoagulants which has come, that after 1 year, if the patient has to take newer anticoagulant for some reason, the patient should not be on aspirin, clopidogrel, any of the antiplatelets. It means that even the subcutaneous injection of the dominated heparin is good enough, and the last dose should be 12 to 14 hours before the surgery or anything. So if you want to completely come off the antiplatelet, there are a lot of biopsy, prostate biopsy and all. They say that you need to stop for 5 days. So you can stop the antiplatelet with aspirin, give some low molecular heparin, and last dose should be 14 hours before the surgery, before the biopsy or surgery.
So can I add to
Dr. Devi, Dr. Devi.
Sir, just wanted to add to the eye part. There are retinal surgeries and glaucoma surgeries where we would need to stop for about 72 hours if possible. But for cataract, because it's a clear corneal incision now and a 2 millimeter incision, most of the surgeons, they don't stop.
Yeah.
We are very happy to let them be like that because it's a avascular structure.
Absolutely.
Dr. Gandhi, sir.
Sir, if a patient is on single antiplatelet and he had a severe bout of epistaxis, so should we stop the antiplatelet or should we wait
So
for?
if the patient is on single antiplatelet, you can stop it for a day or two, but believe me, this is not because of the antiplatelet. So either the patient has got accelerated hypertension or nose bleeding or some nasal trauma. But you can stop for a day. As I said, that up to 2 days it doesn't cause really a problem, but beyond that the risk of stent thrombosis becomes higher.
Sir, just before I give to the masters, one last question for everyone's benefit. Those people who are on DAPT or SAPT, their main concern at times is ecchymosis, nothing else. Nothing else. You do any test, they're all normal. And many times I talk to you regarding some of the patients and you say, इसके अलावा कुछ है? कोई मेलिना है? कुछ है? Nothing. And they don't have anything. And you say, please continue and reassure them that nothing will happen. Sir, just a word on that.
Yeah,
Especially elderly people, more than 80 years, frail people. Lot of ecchymotic patches, lot of bruises, easy bruises, and then you say, SAPT, continue, nothing to worry.
Yes, I always tell my patients, so obviously the scientifically the answer is that there is no harm with that ecchymotic patches, because that's, and I tell them that this is how we find that you are taking the medicine. So you continue it doesn't cause any harm. So it does more benefit than harm.
Thank you very much, sir.
Is alternate day justified?
Yes, so 2 days a week is also justified.
Dr. Viveka did that for my last patient who had a lot of ecchymotic patches and he was just worried. He said, क्या problem क्या है? मैंने कहा सर वो ecchymotic patches बहुत ज़्यादा हैं, वो दिमाग में घुस गए हैं. He said ठीक है दिमाग से निकालो, twice a week दो.
Because these are the drugs which have got almost 5 days of duration of action, so you can give it 2 days a week. So obviously none of the trials have done in these situations, so it is an off-label use, but this is a very frequent one.
Dr. Tulsi sir.
So let me say at the beginning, what a nice talk, Dr. Viveka, as usual. So after those many complex questions from our colleagues, let me ask you some very simple questions. Okay. Duration. Optimal duration can vary based on individual risk factors. High risk patients, like as you said, diabetic patients, patients who have multi-vessel disease and have multiple stents, and also in patients who have left main bifurcation lesions, and of course prior stent thrombosis. You probably need to continue these DAPT for at least a year.
Yeah.
What do you say, sir? High risk patients need to continue DAPT for a year and beyond.
So high thrombotic risk, even we go beyond 1 year, so up to 3 years we can say
30 months.
So I think if you look at the Pegasus data, that clearly shows the risk of repeat myocardial infarction and all goes down significantly. High thrombotic risk is a different ball game than high bleeding risk. With high bleeding risk, we can de-escalate after a month. High thrombotic risk, we can continue up to 3 years.
So when you talked about the high bleeding risk, let's dwell a little about on the Sweetheart trial as compared to the Cmes trial and also the Plateau trial. So the Sweetheart trial talked about patients who were elderly, patients who are 80 years and beyond. So bleeding risks here is much more as compared to the Plateau and the Cmes Triton trial, where these patients were younger patients. So younger patients probably do not have much bleeding risk as compared to the elderly people 80 and beyond. So talk us about the Sweetheart trial, sir.
Yeah, so I think that's again a very good registry kind of thing where the real life scenario came and it clearly showed that if the patient is younger, obviously they will tolerate it much better and the risk of bleeding will be significantly lesser. Whereas if the patient is elderly, 75 plus age group, patient has got non-left main, non-bifurcation disease, then there is no point in continuing this DAPT for longer. So I think this trial clearly showed that it is quite safe to use single antiplatelet and de-escalate at a much earlier stage compared to the younger patients. In younger patients, you can think that the risk of bleeding and all kind of bleeding will be significantly lesser.
Sir, would you like to de-escalate here? So give a lower dose in elderly people or what? Because I am going to probably present one case, one unique case. Tell us, sir.
Yeah, so I think if you see that elderly patient, we have many times de-escalated ticagrelor from 90 milligrams to 60 milligrams. Even prasugrel from 10 milligrams to 2.5. So there is a data from Japanese trial which shows that even 2.5 milligrams is good enough. And even the clopidogrel, you can give it an alternate day or 2 days a week depending on the patient's bleeding risk. So I think completely switching it off would be risky. You need some amount of antiplatelet. Having said that, in our life, general practice, we could see that there are many patients who have stopped all the antiplatelets and still they are doing okay, but there will be almost 0.3% risk of annual risk of thrombosis, and that could be disastrous. So if the patient has got more than one stent in one of the main arteries, better to continue at least single antiplatelet for lifelong.
Very true, sir. Let me take you to a case. 87-year-old man had chest discomfort, heaviness in the chest, with dyspnea. ECG showed acute ventricular infarct. An astute cardiologist like Dr. Viveka diagnosed this case and started him on DAPT. Aspirin with clopidogrel. Dr. Chauhan, are you with us? Okay, he says yes. For 5 days. After 5 days, this patient, Dr. Viveka put on ticagrelor with aspirin. So what did we have this? The patient had hemorrhage. The
Where?
platelet dropped to 16,000.
Hemorrhage where?
Intracranial hemorrhage.
Okay.
So this also cardiac tamponade. So this patient was intubated and recovered after intubation, and this patient was LDH was very high, also landed in acute heart failure. So why would that be? I'll ask you later, sir. This patient also went into a cardiac arrest. He was resuscitated by Dr. Viveka. And finally, this patient was on Tika. After 5 days of clopi and aspirin, this patient had massive hemorrhage, had a TPP, thrombotic platelet purpura, thrombocytic purpura, thrombocytic purpura. Yeah, TPP. No. Thrombotic.
Thrombocytopenic purpura.
Cytopenic purpura, TPP.
TTP.
So how common is that with ticagrelor? Let me finish, Dr. Chauhan. This patient recovered. Also, this patient also had a CKD and of course acute heart failure with a pro-BNP levels of 36,000. LDH was very high, as one would expect. This patient was then stopped by Dr. Viveka on the Tika was withdrawn, and after 5 days the patient recovered. His biomarkers like NT-proBNP and LDH levels fell to normal limits. Even the serum creatinine, he had a CKD, he had an AKI. So serum creatinine from 2.3 fell to 1.3, he became normal. So our cardiologist thought probably, high dose is causing this problem. Let me start this patient, because this patient also had a 95% LAD stenosis, and a cardiologist put a DES in his LAD and he recovered. Now this patient was then probably, was started on a low dose, 45 milligram VD ticagrelor, and what happened? Again he went into acute heart failure. So therein lies the fact that if you have once ticagrelor induced TPP, you need to never start this drug. Talk us about this, Dr. Viveka sir.
Ticagrelor induced TTP.
TPP. And what's the treatment for it?
I think that's again a very uncommon scenario, but we need to, as you rightly said, that we should not re-challenge the patient, because then if you try and re-challenge, so you need to change it to the other antiplatelet, and best P2Y12 inhibitor in this situation is clopidogrel plus aspirin, because it is an event which happens in less than 1 month time. We cannot switch to a single antiplatelet, so it's better to keep them on aspirin and clopidogrel, and that would have solved the problem.
What do you think, Dr. Viveka, was the cause of the acute heart failure in this patient?
Sir, last question.
So it could be either, one of the
Myocardial ischemia, microinfarcts, platelet thrombi in the cardiac, microcirculation.
Yeah, so I think the thrombus formation in the stent and microcirculation is the most plausible cause.
Thank you, sir.
Dr. Kada sir.
सर मेरे दोस्तों ने इतने अच्छे सवाल पूछ लिए, मैं गदगद हुआ, खुश हुआ मैं सिर्फ ये कहना चाहता हूँ कि सर फ्रॉम मिनिमम ऑफ 1 year to maximum of 1 year we have achieved over the years. जब ये स्टार्ट हुए थे DAPT तो हम ये कहते थे कि कम.
When we give antiplatelet, we try to, make more than 90% or 60% of the platelet is functional. So in that situation, if already the platelet is so low, then you don't really need to give antiplatelet. If it goes beyond 50,000, you need to watch for 2-3 days. If it climbs to 80,000, then you start single antiplatelet. If it is more than 1 lakh, then only dual antiplatelet.
सर मेरा लास्ट कमेंट है डॉक्टर चौहान के केस पे ट्वाइस ए वीक, तो आने वाले टाइम में शायद हमारे हर बुधवार पे एक उसका फिक्स हो जाएगा once a week. Thank you so much.
Sir,
How do you reverse this thing, low platelet counts here? Is the fresh frozen plasma have no effects here? Probably the TPE is the modality of choice here?
Yeah, so we give NTP.
Not platelets, no. Because they will be inhibited again.
So we always say that you can infuse the platelets and then you monitor the platelet count, because it is only antiplatelet. So you don't have to give anti-thrombotic.
Sir, therapeutic plasma exchange is the modality of choice here, not the platelet infusion.
Plasma exchange and steroids we give.
Thank you, sir.
also, Dr. Tulsi, we have to remember one thing, because I have been a case of this myself. I had a massive anti-wall MI in 2003, was admitted to Escorts, and I was given GP2 A3B inhibitor, sir, intracoronary before the stenting, and I went into severe thrombocytopenia. My platelet count touched 20. Dr. Parveen Chandra was my treating cardiologist, and I asked him, sir, will I survive? I have very small children. My daughter was only 5.5 and my son was only about 4.5. Only 11-12 months difference between them. And he looked at me and he told me, please understand one thing, we gave you the best treatment possible, and I agreed because I was pain-free in 5 minutes after stenting. The worst kind of chest pain that you can get with a balloon in the middle of your chest trying to rupture, and you want that balloon to rupture because that will give you that will lead to a condition which will be pain-free. And he told me, I have given you something which has decreased your platelet count, and now they are going to have some duration before you recover. Sir, he gave me nothing. He gave me nothing. He did not, he said, Dr. Chauhan, at your age of 42 years, if you had an extensive anti-wall MI, which could have taken away your life, the last thing I want to give you is activated platelets. So, at times you just have to wait, and after 3 days, my count started increasing from 20,000 to 25 to 28 to 30 to 35 to 40, but my count still remains only about 1.3 to 1.5.
That's okay, sir.
It doesn't increase.
Abhi bhi, sir, abhi bhi.
Abhi bhi.
That's okay, sir.
But it's fine, it's fine. So what Dr. Viveka has told you, sir, please remember, do not be in a hurry to increase the platelet count, because the last thing that you want in an acute coronary situation is to give the patient activated platelets. Remember their quality, adhesibility, aggregability, and they are very aggressive. So I do not want an acute stent or a subacute stent thrombosis. Sir, beautifully presented. Wonderful question, Dr. Kumar.
My last question.
We need to wind up.
No, sir, talking about the ACG 2025 recently in Chicago, they talked about mechanical support, and I'm talking about the microaxial flow pumps, which probably are the best circulatory support today. What about the IABP has received a class 3 recommendations. What happens about the legal complications on hospitals who have IABP for mechanical support? So talk us about this newer microaxial pump, sir.
Yeah, so I think it's been there. So we have been, it's like a non-permanent.
You have it there at your hospital?
MCS support. It is
Thank you very much, Dr.
we
Uchi,
do
sir.
let him complete like an LRAD, but it is prior to that, it is the MCS support, and we do it. We have got now percutaneous MCS support, which is called Ambula device. With that, we can keep the patient very complete.
Thank you, sir.
Sir, I would request, no, come here. Dr. Podar, idhar aaye. Dr. Podar, idhar aaye. Dr. Podar is going to organize we will announce it next time, but those of you are here, you must know that, please understand, Dr. Podar is going to organize a conference, a day-long conference on 17th of August. We will announce it full-heartedly next CME, but I also want to tell you of about 25 guys who are here. I have 30 free registrations for Delhi Endocrine Society Conference of 16th of August in Pride Plaza. Any of those guys who are interested for a free registration for this DesiCon may contact me with their telephone number, with their email and with their DMC number. I have 30 free registrations. The first 30 will be given there. Sir, this is time to thank Dr. Viveka sir and the wonderful team of सर एक फोटो चाहिए और सर आइए खुशबू इधर आ जाओ नवीन डॉक्टर साजिद डॉक्टर यू डिडंट आस्क